Good morning, everyone. Welcome back. Happy Sunday. I am Barry Vapnik, and I am Director of Community Relations for the HypoPARA Association. It is my pleasure and honor to introduce Dr. Rubin, who is one of my favorite people in this world, who is from Columbia in New York City. Thank you, Dr. Rubin, for joining us today. She will be talking about the long-term effects of HypoPARA. So Dr. Rubin, the stage is yours. Thank you so much and good morning.
Good morning. Thank you so much. Such a pleasure to be here. I'm going to pull up my slides. Great. You can see the slides, right? Okay, great. Okay, so I'm going to be talking today about the long-term complications of hypoparathyroidism. These are my disclosures. An outline of what I'm going to discuss is here. I'm going to start out just by pointing out some of the differences between the immediate manifestations of hypoparathyroidism versus the long-term complications. Then I'm going to review the management guidelines because those are relevant to how we think of managing the long-term complications. Then I'm going to focus on long-term complications in 4 organ systems: the kidney, the brain, the vasculature, and the skeleton. Although there are long-term manifestations in other organ systems, these are ones that there is probably the reason to be more concerned about, and then talk about how we need to be able to predict and monitor and prevent these complications, and then tell you about a natural history study that is trying to do that. So the immediate consequences of hypoparathyroidism are usually pretty obvious, and I know, of course, you know this all very well, but these can include numbness, tingling, cramping, and just to read some quotes here from patients of mine, I can't tell you how many times I've been to the ER because my hands cramp up, they curl up into a big cramp, and you can't use your hands, and it's so painful. Or another mom saying that she feels like she can't drive because her hands can become too numb to control the steering wheel. The immediate manifestations of hypoparathyroidism also include neurologic dysfunction. So people might feel, I can't remember somebody's name that they just told me, and I'm worried, am I getting Alzheimer's? But maybe it's just that my calcium is low, but feeling that they're not functioning as they should be. And this can also be associated with symptoms of anxiety or even depression. People can feel so anxious about technique coming back and maybe even needing to go back to the ER, and that could lead to an anxiety syndrome. And of course, the immediate consequences of hypoparathyroidism can interfere with daily function. People feel like they can't participate in their usual events with their families. Somebody said she stopped cooking, but it's just too effortful and too hard to figure out, and she just doesn't have the energy for it. So I think, you know, the immediate manifestations of hypoparathyroidism aren't always obvious, but usually they're pretty apparent by these symptoms of low calcium and brain fog. So the long-term complications might be less obvious because someone might not feel symptoms, they take time to develop, and they could be insidious. But it's very important for us to think about these, of course, too. And in general, it seems that the long-term complications are associated with there being increased calcium throughout the body in places where there probably shouldn't be extra calcium. And this is the case in the kidney, in the brain, in the vasculature, and in the bone. So I'm going to briefly talk about the management guidelines. I know people were just talking about them because they're finally published and available, but these are relevant for how we want to manage the long-term complications. So the first goal of management is to keep the albumin-corrected serum calcium in the lower half of the normal reference range, or even a little bit below the normal reference range. But at the same time, we don't want hypocalcemia symptoms to develop. We also want to make sure that the urine calcium doesn't get too high. So in women, that means that the 24-hour urine calcium should be less than 250 milligrams a day. And in men, it should be less than 300 milligrams a day. And we don't want phosphate to get too high in the blood. And this actually is particularly important for preventing long-term complications. And so the conventional management, which probably we're all familiar with, consists of, first of all, taking calcium, and most people take this either as calcium carbonate or calcium citrate, and the amount that people need could vary widely. Calcium carbonate, you get more bang for your buck. It has more elemental calcium in it, but the caveat is that you need to take it with a meal. Calcium citrate, even though it has a little bit less calcium per pill, doesn't need a meal or the presence of gastric acid. The other mainstay of conventional therapy is activated vitamin D, which in this country is calcitriol, also known as Rocaltrol. And again, the dosages that people need could be widely variable. And the way it works is by increasing the absorption of both calcium and phosphate in the intestine. So it'll raise levels of both of those electrolytes. And it has a short half-life. It lasts about 6 hours. And then many patients also take what we call regular apparent vitamin D as opposed to the activated vitamin D. And here, again, the dosages could vary widely, but our goal is to get the vitamin D level into the normal range. And in general, that's thought to be somewhere around 30 nanograms. Some people say a little bit less is fine. Some people say a little bit more is fine, but that's the general rule of thumb. And then some patients also use thiazide diuretics. This is a water pill that can block the amount of calcium that's being lost in the urine and hold on to that calcium and raise it in the blood. So some patients, particularly those who have high levels of urine calcium, will use this also as part of their management. The other important part of management is the option of using PTH. So PTH is not available for the indication of hypoparathyroidism right now in this country. It is available as off-label for Teo use, as we know. And hopefully there are a number of new PTH treatments that are coming down the line and hopefully will be available. But the guidelines say that PTH treatment is recommended if adequate control is not able to be achieved with conventional therapy. And what that means is that if somebody is still having symptomatic hypocalcemia, or their serum phosphate is too high, or they have kidney insufficiency, or their urine calcium is too high, or they're having poor quality of life while on conventional management, that would be someone who would be a candidate for PTH therapy. So with that background of what the managements can potentially be for hypoparathyroid patients, I'm going to turn now to talk about these 4 buckets of long-term calcifications. And for each complication, I'm going to try to answer the question first, is there evidence that there is excess calcification in that organ? And does the calcification lead to damage to the organ and impair its function? What are the effects of hypoparathyroidism treatments on the complication? And finally, how can we predict who's at risk for this complication? How can somebody know if this is something that's likely to happen to them? So we'll start with talking about the kidney. So is there evidence that there's excess calcification in the kidney? And it is very well established that there is an increase in kidney calcifications and kidney stones in patients with hypoparathyroidism. One study that showed this was a large study that looked back at data in American insurance claims, and it showed that in about 8,000 hypoparathyroid patients who were compared to 40,000 people who did not have hypoparathyroidism, that there was a 6.9 times higher rate of having kidney calcifications and a 1.8 times higher rate of having kidney stones. And in fact, these numbers might even be an underestimate because the way this study was designed was it was looking back at these claims or records of hypoparathyroid patients who had had imaging of their kidney. but it could very well be that there were patients who had silent kidney calcifications or even kidney stones that weren't picked up, because this wasn't a systematic study where every hypoparathyroid patient underwent the kidney imaging. So it's very possible that these numbers are even higher because it could have been that there were patients who had kidney calcification or kidney stones, and it wasn't even imaged, so we don't even know. Now, does this calcification seem to cause damage to kidney function? And the answer to that also seems to be yes. There is a large retrospective, so again, a looking back study on records from Denmark, where all hospitalizations are entered into one system. And looking back at these records, it was shown that patients who had post-surgical hypoparathyroidism had a 3-fold increased risk of chronic kidney disease, and patients who had non-surgical hypoparathyroidism had a 6-fold increased risk of chronic kidney disease. And these numbers are really something that we need to take seriously, because it's well established that having chronic kidney disease increases the risk of going on to having cardiovascular disease and even increases mortality. So how do our hypoparathyroidism treatments affect kidney complications? Well, we know that calcium supplements and active vitamin D do increase urinary calcium levels. And this actually happens even to a greater extent in patients who have autosomal dominant hypocalcemia. So it could be that taking calcium supplements and active vitamin D, which of course hypoparathyroid patients must do, actually can be worsening kidney function. On the other hand, it's possible that with PTH treatment, kidney function is maintained or preserved. And this is just some data from a study we did at Columbia with HypoPARA, where patients who were on HypoPARA for 12 years had their kidney function, which is known as the estimated glomerular filtration rate, seen on the y-axis, measured. And you can see that over 12 years, this measure of kidney function really remains stable in the setting of being on PTH therapy, suggesting that this seems to prevent kidney damage from occurring. But nevertheless, we still have areas of uncertainty, because in these retrospective studies that I mentioned to you, where they looked back at patient records, there's little information about the effects of treatment. So we don't know, was somebody who was on a higher dose of calcium more likely to have kidney calcification? So it's really hard to say, does taking calcium and calcitriol accelerate the decline in kidney function? Or on the other hand, does taking PTH slow or even reverse kidney dysfunction? So these are obviously really important questions that we need the answers to. How can you predict if somebody is at risk for developing kidney complications? So we think that someone who has risk factors that mean that they have higher calcification in general are also going to be at increased risk to have worse kidney function. So that means, has somebody had hypoparathyroidism for longer? And these are data that show, again, this was a retrospective or looking back study, but looking back at records of patients with hypoparathyroidism, it showed that here, for each progressive year of having hypoparathyroidism, this measure of kidney function, known as the GFR, or the estimated glomerular filtration rate, decreased with each progressive year of having hypoparathyroidism. We also know that if someone has more episodes of high serum calcium, or along with that, if they have higher levels of the serum calcium multiplied by the serum phosphorus, that's a term that we call the calcium phosphorus product. And we think that if that number is higher, the calcium times the phosphorus, that means that there's an increased risk of kidney calcification. But we still need more information to say if somebody is going on to be at risk for kidney calcification and kidney dysfunction. We don't really know how our biomarkers, and by that I mean a urinary calcium test, a phosphorus test, or even this product of multiplying the serum calcium and the serum phosphorus, how good they are at being able to tell someone, this is your number, you're at risk for kidney complications. And part of that is because a lot of these estimates that we're thinking about are based on a different group of patients, and that is patients who have chronic kidney disease. And in patients who don't have hypoparathyroidism, but who have chronic kidney disease, it's well established that having an increase in your 24-hour urine calcium, an increase in your serum phosphorus level, and in this number of the calcium phosphorus product, specifically being higher than 55, that all of those are associated with kidney calcification and worsening kidney function. But we actually don't know that that's the case for hypoparathyroidism. We assume that it is, and it most likely is the case by extrapolating from chronic kidney disease patients, but that's never been proven. And if you think about it, chronic kidney disease is actually a disease where patients have high parathyroid hormone levels. So it might be a little bit of a stretch to extrapolate from that to patients who have hypoparathyroidism. Again, I think these predictors probably do hold up in hypoparathyroidism, but it's just never been proven. And maybe there are other risk factors we can look for to be able to better say to someone you're at high risk for developing chronic kidney disease as a consequence of your hypoparathyroidism. One factor is protein in the urine. So I don't think there's any or much data looking at this. And this is a risk factor that's highly linked with going on to develop kidney disease. Or a relatively new marker that we could maybe think might be useful is FGF23. So this is a molecule that's made by bone cells, and it's high when serum phosphate is higher. And the job of this molecule is to help the body urinate out extra phosphorus. And there are some data that seem to show that this FGF23 molecule is too high in hypoparathyroid patients and actually isn't working as it should, that maybe there's some resistance to it and it's not being able to accomplish its job of increasing urinary phosphorus excretion. And we also know that this molecule can be predictive of kidney dysfunction and actually also cardiovascular disease. So it's quite possible that if we were to measure FGF23 in patients with hypoparathyroidism, this might be able to be a predictor of being able to say you're at increased risk for going on to have kidney complications. I'm going to turn now to the next long-term complication that I'll be discussing, which is the brain. Is there evidence for excess calcification in the brain? And yes, there is. It's known that there are calcifications in a part of the brain, which is called the basal ganglia. And you could see this pictures from a patient of ours where the arrows point to bright spots or calcium in this area of the basal ganglia, which shouldn't be there. And the job of the basal ganglia is to control voluntary movements. And when somebody has Parkinson's disease, that's associated with basal ganglia abnormalities. And Dr. Clark conducted a study which looked back in the charts of hypoparathyroid patients who also had CAT scans of the head. And he found that 25% of those scans showed basal ganglia calcification. And specifically, it was the non-surgical hypoparathyroid patients who had a greater burden of basal ganglia calcification. So there clearly is evidence that there is calcification in the brain that's going on. But what we really don't know is, what does this mean? So, of course, you're all very familiar with the crippling symptom of brain fog, which involves slowed thinking and difficulty performing daily tasks. It could also involve difficulties with memory, with executive function, also with slowed processing speed or how fast someone's able to process information. What we don't know is, do the brain calcifications actually relate to the brain fog? We also don't know if brain calcifications relate to seizures or even relate to movement disorders. There are a few patients with hypoparathyroidism who can develop symptoms of Parkinson's disease. So are these correlated with having the basal ganglia calcifications? What are the effects of hypoparathyroidism treatments on brain calcifications? Well, you could speculate that maybe taking higher dosages of calcium and vitamin D are going to increase the risk of more calcifications in the brain, but we really don't know if that's the case at all. We could also speculate that being on PTH treatment might lead to basal ganglia calcifications, regressing or at least stabilizing. But we don't know also, and that's a question that needs further study. And then we don't know who is at particular risk for having basal ganglia calcifications. In Dr. Clark's study, the hypoparathyroid patients were all having CAT scans for other reasons. It wasn't a study where all the hypoparathyroid patients were told, now you're going to have a head CT and we're going to be able to see just how common these calcifications are and do these calcifications progress over time. So there could have been hypoparathyroid patients who had basal ganglia calcifications, but just didn't have a head CT. So maybe the number of calcifications that Dr. Clark found was actually even underestimated. And we actually really don't have information to be able to tell someone you're at increased risk for this complication of hypoparathyroidism. And in fact, we don't even know if this is something that we should tell all hypoparathyroid patients that they should be screened for. Should everyone with hypoparathyroidism have a CAT scan, maybe just one time or maybe every few years, to see if this is a problem there? We just don't know that. I'm going to turn now to the third long-term complication, which is vascular calcification. Is there evidence for excess vascular calcification? And there is some evidence. There is a study that showed that there was increased coronary artery calcification. Some of you might have heard of this measure. It's called the coronary artery calcium score, which you can get from a CAT scan. And this was found to be increased in non-surgical hypoparathyroid patients. And in another study, it was found that there was an increase in carotid intima thickness. This is a measure of plaque building up in the arteries that supply blood to the head. And this was also found to be increased in non-surgical hypoparathyroid patients. So these studies do seem to suggest that calcium might be building up in excess in the blood vessels of patients with hypoparathyroidism. And this is something that's potentially important because we know that vascular calcifications can be linked to cardiovascular disease, especially in a patient who already has some degree of kidney dysfunction. And the Danish National Registry study, which looked back at patients, actually did show that cardiovascular disease was increased in non-surgical patients, that there was an increase in ischemic heart disease. This means when the blood vessels to the heart aren't getting enough blood, and that there was an increase in abnormal heart rhythms. And in the US insurance claims study that I mentioned before, it was found that over 5 years, there was a 39% increased risk of coronary artery disease, a 45% increased risk of stroke, and a 68% increased risk of abnormal heart rhythms. So it does seem that this abnormal calcium buildup in the vasculature and in the heart vessels can indeed be affecting the function of the heart. How do our hypoparathyroidism treatments affect vascular calcification? Well, these are some areas of uncertainty. Can it be that taking more calcium supplements can increase the risk of calcium building up in the blood vessels? It is kind of logical to expect that it might be the case. There is evidence that in the general population it does. And there are also osteoporosis studies that show that taking more calcium for osteoporosis does increase the risk of vascular calcification. But in the hypoparathyroidism studies that looked back at these cardiovascular manifestations, we really don't know what the dosages were of calcium and active vitamin D that led to these increased presence of cardiovascular risk and coronary artery disease or stroke. So it's hard to know if this is indeed going to increase the risk. We really need more information about that. And then we also don't know if taking PTH might slow or reverse these vascular calcifications and maybe prevents these cells in the blood vessels from acting inappropriately like bone cells and turn them back into acting as they should be, more like blood vessel cells. We also really don't know how we can predict who's at risk for vascular calcifications and cardiovascular disease. First, we don't know if it progresses over time. We don't really have longitudinal data on that. We also are probably missing other important risk factors. So these studies haven't included whether the vascular calcification in hypoparathyroid people was associated with other risk factors like smoking, maybe even hyperthyroidism. We know hyperthyroidism could be associated with abnormal heart rhythms. Did that play a role? Or even hypothyroidism. Hypothyroidism can be associated with increased cholesterol, and maybe having increased cholesterol contributed to the risk of having cardiovascular disease. So these are all potentially contributing things that need to be sorted out. And it would be great if we had biomarkers or blood tests so that we could be able to tell someone, you're a person who's at increased risk for vascular calcification and heart disease. But right now we don't have those. One potential biomarker is a protein called sclerostin that's made by bone cells and has been shown to be elevated when vascular calcification is developing in association with low bone formation. And this might be something that could be a particularly helpful predictor for hypoparathyroid patients, because we know that bone formation is low, and it could maybe be predicting increases in vascular calcification. There are two other new biomarkers that also might be useful to be able to tell someone if they're at increased risk for abnormal calcium in their blood. One is a new test which measures calcium phosphate crystallization in the blood. So in other words, you draw somebody's blood and it'll tell you how long it takes for calcium and phosphate to precipitate into an abnormal clump in the blood. If it happens really quickly, then that means that the risk is higher. So this is, a new blood test that can be done. And it also not only shows how quickly that calcium and phosphate will precipitate in the blood, but it has been shown to be a predictor of increased risk for cardiovascular mortality. And then another predictor we can draw from the blood is one that's related to genetics. So there's something called microRNAs. These control gene expression by regulating the RNAs in the cell. And there are specific microRNAs which can be just simply checked in the blood that predict the risk of vascular calcification. And it's been shown that higher levels of these certain microRNAs can actually switch the vascular blood cells to become more like bone cells in the vasculature, and thus increase the risk of vascular calcification. So these are two new tests that could potentially be useful to be able to predict for someone how likely they are to develop these complications of calcium in the blood vessels. And the last category I'm going to talk about is long-term complications in the bone. So is there evidence for excess calcification also in the bone, as in the other organs we've discussed? And there is. The bone, if you will, becomes overcalcified in hypoparathyroidism. So the same way there seems to be extra calcium in other tissues, there's also extra calcium in the bone. And this has been shown in bone mineral density tests and also in bone biopsy tests. And you could just see here, these are two pieces of bone from somebody without hypoparathyroidism and from somebody with, and you could see how there's extra bone in the hypoparathyroid sample, so that the bone is even losing the normal structure and becoming overly thickened. Does this translate into damage to the bones, i.e. does it mean there's more fractures? It might be. In that large Danish registry study, it was found that there was an increase in upper arm fractures, about a twofold increase in risk in patients with non-surgical hypoparathyroidism. And there also have been small studies that show an increased risk of spine fractures in postmenopausal women with both surgical and non-surgical hypoparathyroidism. So, we can't say for sure, just because the disease of hypoparathyroidism is so rare that it's so hard to get fracture data, but it does seem that there might be evidence that this overly thickened and overly calcified bone might be bone that's more prone to fracturing. What are the effects of our hypoparathyroidism treatments on bone complications? Well, PTH treatment probably does have an effect. This picture is just to make the point that bone consists of two compartments, the inner cancellous compartment, which kind of has this honeycomb structure to it, and the outer cortical bone, which has this smooth, solid structure. And it does seem to be that with parathyroid hormone treatment, there is a decrease in the thickness of the outer cortical bone. And this has been shown using bone density as a tool. And it's also been shown using bone biopsies. There seems to be an increase in tiny microscopic holes in that outer cortical bone, which perhaps could make the bone weaker and more at risk for fracturing. On the other hand, even though bone seems to be removed with PTH treatment, one could speculate that maybe the actual bone quality is improved because overly mature, overly mineralized bone is being removed, and new, younger bone, perhaps with better bone quality, is being replaced instead. So even though with PTH there is a decrease in cortical bone, we're not sure if this means that there is actually an increased risk of having a fracture in the setting of PTH treatment. So we clearly need more information about this important question. Who is at risk for having bone complications? I think postmenopausal women, because those are the people who are already at risk in general for bone loss and fractures. And it does seem from the studies that are available that it's the non-surgical hypoparathyroid patients who are at greater risk for having fracture as opposed to the post-surgical hypoparathyroid patients. And hopefully we can get more information to answer this question from bone imaging, because when we do bone density with DEXA, you can also do a test at the same time called vertebral fracture assessment, which just means looking at the sideways picture of the spine. And you could see if there's any silent fractures in the spine that have occurred, perhaps even without the person knowing. We can also use high resolution imaging of the bone, which gives a very detailed picture of the bone, almost like a non-invasive bone biopsy, and can also perform calculations of bone strength that can predict fracture risk. So maybe with using these additional bone tests, it's possible to predict who is going to be at risk for fracture and whether the PTH treatment is reducing or increasing that risk. So I'm going to briefly recap these areas of uncertainty that I've mentioned throughout the discussion. So in terms of the kidney, we still need better data about how common it is to develop kidney calcification and kidney stones. We're still not really sure whether taking calcium and calcitriol can worsen somebody's decline in kidney function and whether taking PTH can prevent that from happening. We also don't know whether the biomarker tests like urinary calcium that are used in patients with chronic kidney disease have the same predictive value for kidney dysfunction or kidney failure in hypoparathyroid patients. And we don't know whether other biomarkers like FGF23 might help us to predict who's at risk to go on to develop kidney dysfunction. In terms of the brain, we really have no idea how common basal ganglion calcification is. There's been no study that just took hypoparathyroid patients and going forward, checked them all for basal ganglion calcifications. We don't know what the risk factors are. We don't know if taking calcium and calcitriol worsens the risk for these brain calcifications, or PTH maybe protects people from that risk. And we also don't know if whether having these calcifications means anything. Does it relate to brain fog or seizures or movement disorders? In terms of vascular and cardiovascular manifestations, we don't know if taking calcium supplements increases the risk of vascular calcification or whether taking PTH is protective for it. We don't know the roles of other risk factors like smoking or cholesterol for developing vascular calcification. And we really don't have good biomarkers to tell us who's at risk for developing this complication, and whether new blood tests that assess the precipitation time of calcium or the genetic control of vascular calcification could help us to give somebody their individual risk profile for developing this complication. And finally, we don't know if being on PTH long-term can end up making the bone less strong or perhaps even more strong. So these questions are really important because finding the answers will help us to predict and monitor and prevent these long-term complications from occurring. So in the last few minutes, I'm going to talk about a new study that we've just started at Columbia, which is a natural history of hypoparathyroidism, which is designed to answer some of these questions. And the goal of the study is to learn about the long-term complications of hypoparathyroidism. And in the study, we're going to monitor the study participants for the development of all of these complications in the kidney, the brain, the vasculature, and the bone. We're going to look at these predictors for these complications using blood tests and urine tests, measuring these genetic regulators in a blood test to see what somebody's personal risk factor is for developing these complications. And we're also going to see in people who are on parathyroid hormone whether the development of these long-term complications is halted or even perhaps reversed. The study involves coming to Columbia once a year for 3 years, as well as having labs done near your home every 6 months. And the tests that we're going to do first in the beginning include genetic testing for patients with non-surgical hypoparathyroidism. And then at each of the annual visits, what the study will include is questions. We want to be able to monitor how frequent and how severe hypocalcemic episodes have been. We're also going to ask the participants to fill out detailed food questionnaires so we know how much calcium and phosphorus and sodium, which is also important for calcium complications, are in people's diets. We're going to do a physical exam, which includes heart rate and blood pressure. And then we're going to do blood tests that include our usual classical measures like albumin-adjusted calcium levels, kidney function, phosphorus, vitamin D. But we also want to look at other risk factors for calcification, like a lipid panel. We'll do thyroid function tests, as hypo and hyperthyroidism can contribute not only indirectly to calcification, but also, of course, to neurocognitive symptoms. We're going to measure bone activity with blood tests. And then we're going to use these newer blood tests to hope to be able to predict who is at higher risk to go on to develop calcification, like the FGF23, which we think can predict both kidney calcification and heart disease. The T50, that's the name of the calcium precipitation timing test. Sclerostin, which is elevated in vascular calcification and with low bone turnover. And these microRNAs, which are genetic regulators, we think, that can predict the development of vascular calcification. We're going to do our usual 24-hour urine calcium test, but we're also going to add a measure of urine protein, which can, we think, be a helpful risk factor for predicting the development of kidney disease. We're going to do thorough tests to assess neurocognitive function. So this involves not only assessing how the person is suffering from cognitive dysfunction, but also objectively testing the memory, the learning, the fluency, the executive function, and processing speed so that we can pinpoint which domains specifically are compromised with brain fog. And we're going to do tests of quality of life to assess symptoms and fatigue, anxiety, and depression. And we're also going to do motor function tests to be able to see, is there any subtle abnormality in voluntary motor skills. And we're also going to be doing imaging. So this is really to focus on how the organs are affected or not effective. So we're going to use high resolution bone imaging. And this is like a cross section of somebody's leg where you could see this is the tibia, the wider bone, and this is the fibula. And this allows us to look in a very detailed manner at the microstructure of the bone and to calculate, is this bone likely to be strong or weak? But what we can also do, which you see here, these green circles on the 2-dimensional image or these whitish kind of tubes on the 3D image, These are pictures of vascular calcification. So in addition to measuring the bone, this high resolution test can also quantify just how much calcium is building up in the vasculature, so that we'll be able to see how much of it is there and is it associated with developing complications like cardiovascular disease. We're also going to be doing brain calcification assessment with CAT scans. You can see here it's brain calcification on a CAT scan. We have a dedicated neuroradiologist who is going to be evaluating the CAT scans for us. We're also going to be doing abdominal CAT scans. So this is to look at kidney calcification and kidney stones, as you could see this arrow is pointing to here. But we can also look for calcification in the aorta, one of the great vessels in the body, when we do an abdominal CAT scan. And this will be another way for us to see, is there vascular calcification that's developing? And we're also going to be doing bone density imaging by our usual test, dual energy X-ray absorptiometry. But we're also going to be able to look at this sideways view called vertebral fracture assessment, which you could see circled here. This is a collapsed vertebrae. And oftentimes nobody even knows that they have this. There could be no symptoms with it, but it is a sign of bone fragility. So we'll be able to assess for this, and we'll also be able on these tests to look for calcification in the aorta. These tests won't be done at each of the annual visits. They'll be done once in the beginning and then after 3 years, so that we can see in the beginning just how common this is. And then we could look at 3 years, has this progressed, and did any of our markers predict from our blood tests, from our urine tests, the progression and who was likely to go on to progress. In terms of who is eligible for our study, it's anybody who's 18 or older. Any type of hypoparathyroidism is appropriate for the study. Patients with all types are welcome. There's no exclusion for that. Patients who are on conventional management, so meaning calcium and active vitamin D, are welcome to participate. And patients who are on parathyroid hormone are also welcome to participate, because one of the questions that we want to answer is how these complications progress in people who are on conventional management as compared to in people who are on parathyroid hormone. So this includes people who are taking Forteo, people who are still on Natpara from the special use program, and people who are currently taking investigational drugs, including TransCon PTH, AZP3601, which is a new long-acting PTH that is being studied, and patients who have autosomal dominant hypocalcemia who are on encaleret are also welcome to participate. So if anyone is interested or has a family member who's interested or just has questions about the study, please don't hesitate to email me or to call me. Our goal is to recruit 95 patients, and we're planning to do that in the coming months. We do have funds for travel to Colombia for the study. So our hope is that this study is going to be able to shed light on questions that haven't been answered and that will impact the long-term health of people with hypoparathyroidism. So with that, I'm going to end the talk, and I'm happy to have questions and discussion now.
Thank you, Dr. Rubin, and congratulations on getting approved for this natural history project. I bet a lot of people are going to want to sign up for that. So congratulations to you. We do have a lot of questions that came in, and let me just start. Okay, so first question, do you see an impact on lifespan in your HypoPARA patients?
So I think, you know, I don't have enough patients and we don't have a study for that, but I think the literature does suggest that mortality is not decreased. I believe there was one study that maybe suggested there might be a slight decrease in lifespan, but I think the majority of the large studies that are out there don't show a shortening of lifespan.
Okay, great. Let's see. Can you speak about the mechanism that leads to so much muscle pain for us? Trying to understand if it is degenerative in nature and I can expect continual decline, or is it just pain and not necessarily going to rob me of mobility eventually?
Yes, it's possible that the muscle pain can relate to low calcium levels. The same way people can get painful muscle spasms and cramps when the calcium is low. Um, it's also possible that more chronic muscle pain can relate to muscle weakness that's been described in hypoparathyroid patients. I don't know what the physiologic mechanism might be, aside from just low calcium in general, which perhaps, calcium levels are important for muscle function, at a molecular level, even for the muscle fibers to slide correctly across each other to elicit a muscle contraction. Enough calcium needs to be present around those muscle fibers. So it's possible that just chronically low levels of calcium can relate to that muscle pain. I guess it could also relate to neurologic dysfunction as well. With low calcium, we know that there's neuromuscular irritability, and perhaps the nerves innervating the muscle can also be not functioning as they should be.
Okay, thank you. Now, for people on conventional therapy, how does hypoparathyroidism affect the immune system? Are we considered immune compromised?
So there are some data about that from the Danish large registry studies that do show that there is an increased risk of infections in hypoparathyroid patients. The mechanism is unclear, but one theory that was put forth is that it might be related to 125 or activated vitamin D levels, and that higher 125 D levels might be protective against this increased risk of infection. So there is that association that's been put out there. But in terms of clinical practical issues, I don't think it's established that patients with hypoparathyroidism are immunocompromised. So I don't think that we need to think along the lines we would, let's say, for someone who's on chronic steroids, and I think of particular relevance in terms of COVID. So I think it's an area that needs more investigation about immune function and about infection risk. But I don't think there's enough information now to say that somebody with hypoparathyroidism needs to feel worried that they have to follow immunocompromised protocols.
Okay. Have you studied or can you speculate on the risk of brain calcification for those that have used Natpara for 10 plus years?
I certainly haven't studied it. I don't think anybody has. What we can speculate and hope is that in the setting of parathyroid hormone, that perhaps there would be mobilization or removal of calcium from these abnormal calcium brain deposits, such that the brain calcification would regress, or at the very least not progress any further. But I think with all of these areas of abnormal calcification, be it at the brain or the kidney or the vasculature, we just don't know if PTH can remove the calcium. I think there's reason to hope that it would do that and work that way. And I think it would be, of course, fantastic if that was the case.
Okay, great. If a patient has a small kidney stone, is there anything to do? How often should it be scanned, or do you just treat symptoms?
So in terms of the acute management of a small kidney stone, one should be evaluated probably in the hands of a urologist as to whether it's safe just to wait for the stone to pass, or whether it's of concern such that it needs to be removed with a procedure like lithotripsy, which would shatter the stone and help it to pass in fragments. In terms of the bigger picture, patients should be monitored for kidney stones once a year. That could be done with a kidney ultrasound, which has less radiation than a CAT scan. But that should be part of the routine care of anybody with hypoparathyroidism.
And on the topic of 24-hour urine, does hypoparathyroidism affect urinary pH, making urine more acidic?
I think it can. I think it does, but I'm not sure. So I would have to look that up and get back to you. I don't want to misspeak.
Okay. Let's see what else. I wanted to read the question about pregnancy. One second. Okay, I'm planning to get pregnant, but my calcium is usually 8.0 and my phosphorus is 5.0. So I am worried if I could keep the right level while I'm pregnant. To check for the baby's health or normalcy, what shall I do during pregnancy? Are there any special tests?
Such an important question. So the very good thing about being pregnant with hypoparathyroidism is that the hypoparathyroidism usually improves during pregnancy. And that's for two reasons. One is because breast tissue makes something called parathyroid hormone related protein, which acts very similarly to parathyroid hormone. So it's like PTH levels are naturally increasing. The second reason is that the placenta makes calcitriol. It makes 125 vitamin D. So the usual thing that happens is that pregnant moms actually don't need as much calcium or calcitriol pills when they're pregnant. So I would predict that you would likely do well in terms of your calcium levels as well as your phosphate levels while you're pregnant. But it's completely safe to take calcium and calcitriol while you're pregnant. And most pregnant hypoparathyroid patients still do need to take those supplements. It is important to be closely monitored with measurements of calcium and phosphate and magnesium and vitamin D during pregnancy. So this is something that would need close monitoring by an OB. And it's also important for the baby's health, because if the mom's calcium becomes too low during the pregnancy, the baby can sense that, and the baby could actually be born with hyperparathyroidism. So, most women with hypoparathyroidism get through pregnancies fine. You just need really that close monitoring, but it actually should be a good time in terms of the hypoparathyroidism management.
Okay, thank you. Someone has a question about calcium patches. Can calcium carbonate or citrate be absorbed through the skin?
Yeah, I've heard about that, but to my knowledge, there isn't robust evidence showing that that actually works. It could be that I just don't know about it, but I know some patients have asked, and I haven't seen studies that prove that it works, although it would be great if there was such a thing.
And back to the stones in the urine. Are bladder stones considered the same as kidney stones? And are we at a higher risk for these?
Yeah, you would really lump them together, because a stone that passes from the kidney through the ureter down into the bladder, has come from the same place as a kidney stone. So, it's just kind of migrated to the next location. So I would group the risk of bladder stones, along with the risk of kidney stones. It's more common for the stone to remain lodged in the kidney than to progress down to the bladder, but the progression can happen.
Okay, continuing with the kidney talk, if our GFR is still normal but declining, should we be taking any proactive steps to support our kidney function?
I would say doing all the various things to protect kidney function. So one would be making sure that your blood pressure is not high, because that's a risk factor for kidney deterioration. Making sure there's no hyperglycemia or diabetes, because that's another common risk factor for kidney dysfunction. Making sure that there's no high cholesterol. And then you would want to do the kidney specific things, like making sure in general to be well hydrated, of course, not to do so excessively. And then also trying to walk this fine line of taking enough calcium and calcitriol to avoid symptoms of hypocalcemia, but not more than necessary, because your calcium could otherwise go up and you wouldn't even feel it. But chronically elevated calcium levels can contribute, we think, to deterioration in kidney function over time.
Okay, great. Now, different topic. Do we know why some people are more symptomatic than others? Like, how can some people be running marathons while others are in wheelchairs?
Yeah, I think it's a great question, and I don't know the answer to it. I think it's 100% true. I certainly have patients who are not bothered at all, and have other patients for whom the disease is a terrible shadow on their life. You know, I do think even in people with regular parathyroid function, there's a wide variability of what your body feels like is a normal serum calcium. You know, what might feel low to someone might feel high to the next person. Yeah, I think there must be some, molecular pathophysiology, maybe related to PTH receptors, maybe related to calcium sensing receptors. But yeah, I don't know the mechanism for that. I think it's a very important question.
And on this subject of COVID, if you had any patients, how have they recovered from COVID? Are they more susceptible to long-term COVID issues, or are they healing like a regular normal person?
I mean, I haven't studied it systematically or seen studies answering that question. In my anecdotal experience with my patients, it seems that people are recovering from COVID in the setting of having hypoparathyroidism in a similar fashion as people who don't have hypoparathyroidism. Again, that's just my anecdotal observation. It does seem to me that my hypoparathyroid patients do seem to have a more harder time with the post-vaccination feeling sick, and that there is maybe like a risk of a calcium crash afterwards, or just feeling perhaps sicker than someone might feel who had the shot without hypoparathyroidism. But in terms of long COVID, from my own personal observations, I haven't observed an increased risk of that.
Okay, thank you. And on the subject of calcium crashes, how likely is it for a calcium crash to be fatal?
I think, fortunately, it's unlikely. Usually when somebody has a calcium crash, it'll progress, and not reach a severely dangerous state in the very beginning. So, patients will have tetany and feel worse. I think if somebody is having shortness of breath, that is a medical emergency. We do fear laryngospasm, and that can be life-threatening. So I think in the worst case scenario, of course, we worry about a fatal outcome. But I think fortunately, patients who are aware of the signs and symptoms are usually able to be treated long before that becomes a reality.
Okay. Any advice for someone that experiences more bone pain when taking calcitrol?
I mean, just as a rule of thumb, patients who are vitamin D deficient, meaning parent vitamin D, tend to have more bone aches or muscle pain. So maybe I would make sure that my parent vitamin D level is sufficient, because the calcitriol will supply the activated vitamin D, which will keep the calcium elevated in the blood, but it doesn't provide the long-lasting body stores of vitamin D that might be needed in order to prevent those symptoms of pain.
Okay, and there's a question about vitamin K. Is taking vitamin K important to reduce calcifications throughout the body?
Not that I know of. I mean, vitamin K is an important cofactor for one of our bone formation markers, which is osteocalcin. So maybe there could be an indirect way where having enough vitamin K would help bone formation to increase, but I think even that's not clearly laid out. So to my knowledge, I don't think there's strong data saying that someone should be taking vitamin K in the setting of hypoparathyroidism.
Okay, now someone asked a question, but I don't know if it makes sense. Is there a difference between what we measure in blood calcium levels versus the calcium that exists and is usable in our tissues, cells, etc.? Could that explain symptoms in people when blood levels are normal?
Yeah, I think that's a really smart point. So we have the calcium that's flowing through our blood vessels, but then we also have the calcium that's bathing our cells. We call it the interstitial fluid calcium. And it does relate to the calcium levels that are flowing through the blood because there's an interchange between the calcium that's bathing the cells in this interstitial fluid and the calcium that's in the blood vessels. But there can be a difference. And there also can be a lag time. So, if calcium rises or falls in one compartment, it might take time till it rises or falls in the other compartment. So in general, they're kind of correlated, but they can differ.
Okay. Someone wants to know, do you recommend taking more calcium supplements when you're doing something such as exercising or having inflammation? And when do you think taking additional calcium supplements is important to maintain a normal calcium level?
Yeah, I think that's actually usually a helpful thing to do because there are certain triggers for precipitating hypocalcemia. Some people know them well, but sometimes they could be unexpected. So a lot of people know when they're going to do some vigorous exercise just in advance to take some extra calcium, or like the question is alluding to, if there's a viral infection, that could be a trigger for a drop in calcium. Sometimes around the menstrual cycle. I've even had patients who were in situations where it was very hot and their calcium dropped in the setting of being overheated. So I think certainly if you know your trigger, that's smart to do that. And if you don't, but see that you're in a situation where you're starting to develop hypocalcemic symptoms, it's usually the safest thing to err on the side of caution and to take the extra calcium just to be safe, because in the immediate setting, the greater risk is to develop hypocalcemia, not hypercalcemia.
Okay, I think we just have about two more questions. Someone asked, they're using Forteo and calcium carbonate in addition to calcitriol, and their calcium and phosphate levels are stable. But they want to know, is it necessary to control their diet, such as eating high calcium foods and not eating foods that are high in phosphate? They're just afraid of becoming hypercalcemic, having hypercalcemia.
So the Forteo and the calcium and calcitriol would really dominate what's going on with the calcium and the phosphorus. So, you know, it helps to have a balanced calcium in the diet, but and to have low phosphorus, we think, although we need studies on that. But my opinion would be that the diet would not have a great impact because these treatments would really eclipse those effects. So I wouldn't worry that having, you know, extra dosages of dairy would make somebody dangerously hypercalcemic. And hopefully the Forteo is helping to get rid of phosphorus in the urine. So I think that would really be taking care of that concern.
Okay, now I just want to ask you 2 questions regarding your natural history study. One, when will you begin recruiting for this study? And 2, will your study try to show the effects of long-term high bone density?
Yeah, so we're recruiting now. So we would love to hear from anyone who's interested or has questions whenever it's convenient. The long-term effects of having high bone density. Yes, I mean, you know, we won't really expect to see necessarily a statistically significant number of fractures. So it'll be hard to say if the high bone density is overly thick, poor quality bone that's fracturing, but we are doing high resolution, detailed imaging of the bone. And from that, there is a calculation or a simulation that can show how strong the bone is, which relates very well to how likely the bone is to fracture. So in that indirect way, we would be able to see how such a high bone density would relate to the risk of having a fracture over time.
Will you also be studying the effects of people on a parathyroid hormone and the effects of cataracts? Will there, seeing if their cataracts are improved or non-existent being on the parathyroid hormone? Because I know that hasn't been studied. Will that be included in your natural history study?
Yeah, that's a great question. So it's not one of the endpoints, like we're not going to tell people, you have to get checked for it at 1 year, 2 year, and 3 years. But what we are going to do is suggest to everyone that they see their ophthalmologist for annual exams and collect information as to whether any cataract was detected. So it is information that we're going to be collecting, and we will be comparing as to whether it was different in the study in people who were on PTH or on conventional therapy.
Okay, well, thank you, Dr. Rubin. I have so many comments here that are saying your presentation was so great and you have answered so many questions that people have submitted, and everyone is so excited about this natural history project. And we are so grateful for everything that you do, and your presentation was amazing. So thank you, Dr. Rubin.
It's a true privilege, and this whole conference is amazing. So kudos to all you guys.